Like in our example, standing position. So for hernias, standing position. For varicose vein, standing position. Clear? For two things. So reducibility and impulse on cuffing. These two are cardinal signs of an uncomplicated hernia. Now these two you cannot miss. Okay, so this, when I talk about these two, this is like literally passing no that if you are, it is also asked that tell me the two cardinal signs of any kind of hernia, uncomplicated hernia. Then you can say that it is reducibility and impulse on cuffing. So you must know, you must also be able to demonstrate a deep ring occlusion test. Deep ring is located about 2 to 2.5 centimeter above mid-inguinal point. What is mid-inguinal point? It is the point midway between the KSIS and cubic symphysis. What is midpoint of inguinal ligament? It is midpoint of inguinal ligament. So when you say the diagnosis, you will include all the components in hernia. What side? Inguinal or femoral, direct or indirect, incomplete or complete. So when you say direct, most direct hernias are never complete. Most direct hernias are never complete because they are coming through posterior abdominal wall. They cannot like really find a place to then descend all the way inside the scrotum, whereas indirect can, right? So direct, if you are sure of, then usually it would never be complete hernia. Incomplete, reducible, uncomplicated, and whether omentoceal or tendinous. And you must know that when you reduce it, if it makes, if it goes in easily initially, then that is more likely to be omentoceal. Inguinal hernia, it's so they will ask for investigation. Now, for hernia investigation or for any other investigation, please remember this: that when you investigate a patient, you have two aims of investigating, two broad aims. The first aim is diagnosis. So I am investigating so that I can diagnose. And the second thing is I am investigating to identify the etiology of this diagnosis. Right? I'll give you the example as we go ahead. So in inguinal hernia surgery is hernioplasty. That surgery is hernioplasty. So there are very few examples where we do not use prosthetic mesh now, right? By and large, the default is the mesh is always kept. How does the mesh work? So mesh causes foreign body reaction. It induces foreign body reaction, and that is why it causes fibrosis. That fibrosis then helps. The second case I will talk about was breast lump. In your exam, by and large, if at all there is a case of breast lump, it would be malignancy of breast, by and large. Okay? Usually it will be so. Age is important, right? So, CA breast is a, so the way they may ask you is what's the importance of age in case of breast lump? And then you should be able to answer that younger the age, benign conditions, middle age and old age. CA breast is common. They may ask you the gender, what's the importance of gender? And you must know that out of all CA breast cases, it is 0.1% that are male gender. So when they ask you to justify your diagnosis in breast lump, that is carcinoma of breast, that is one part. Obstetric and menstrual history are very important, right? So you must know that early menarche and late menopause. So the overall exposure of breast tissue to estrogen, if that period is longer, the higher are the chances of development of CAS. Now pregnancy is a high progesterone status. So pregnancy is a break. So the more number of pregnancy, less total estrogen. Clear so far? Okay. Medication, oral contraceptives, etc. and family history in mother and sister. Mother and sister, they have anything like that. Examination is of course fully undressed up to the breast, 45 degrees to the cord so that the breasts don't fall apart, fall so out that you are not able to palpate. Inspect for symmetry. I think examination points your textbooks would talk better. But 2-3 things that most of a lot of students say is do not forget describing the contralateral breast. One. Secondly, if you think that you are taking, this is a case of CA breast, I know, but I am not able to palpate the lung. That would be helped only if you palpate the other side. Because you have not palpated so many clinical cases. So what's going to happen is, when you palpate the contralateral breast, you will come to know that this is where the lung is. And then lung is to be described like any other lung. Okay? That goes, the description of swelling is size and fixating, etc. So palpate, in order to locate, palpate with palm, but in order to define the lung, palpate with fingers. So three structure fixating. So consider skin, breast tissue, and P major. That's what is major. So you have to know talk about the lumps fixated to skin, right? And they can be in the ultrasound guidance. And for MET workup, for metastasis workup, what do you require? You require ultrasound of abdomen, and then X-ray chest, and then X-rays of the spine, right? Management is two things. Usually your cases, if at all you have a case of CA breast, it would be stage 3A, 3B, probably it would be there. Because if they keep on getting mass, you already know the diagnosis. So they have to ensure that the skin is intact and it is a breast lump, so to speak. Modified radical mastectomy, you can say most of important, needless to say, one, calcium washout. It would usually be swelling. Now, thyroid, you will have two kinds of here, controlled hyperthyroid. Okay, primary hyperthyroidism and secondary hyperthyroidism. Primary is when both the things happen simultaneously. So the swelling also comes and the patient also gets hyperthyroid. That is primary. Secondary is swelling is there for long, 5 years, 10 years, 15 years, and now the patient develops hyperthyroidism. Few things in history do not say that the patient does not have dysphagia. Okay, thyroid swellings don't cause dysphagia. Dysphagia is difficulty in swallowing when there is something wrong with the oropharynx or the esophagus. What is happening though is that because it's a weighty swelling and with Berry's ligament, through Berry's ligament, it is attached to the larynx. And when you swallow, normally also, your entire larynx gets lifted up. It gets lifted up. So now, it was being lifted up all the time, but the normal weight of thyroid was 20 to 25 grams. But now, the thyroid is enlarged 200 grams or 150 grams. So now the same larynx has to lift 150 grams. So it's more of a discomfort. Okay, so it's not true dysphagia. Dyspnea, they say that in tracheomalacia it can cause, but tracheomalacia in most cases would cause more for trouble post-operatively rather than pre-operatively. Sudden pain in cases of if there is any degenerative changes in the thyroid or any bleeding. Endocrine dysfunction, you must know, right? Hypothyroid, hypothyroid, the hypo would be very subdued kind of patient. Hyperthyroid would be irritability, tachycardia, there will be cardiac components. Intolerance to blood work is routine plus thyroid function test. Always remember that TSH is indirect measurement. So when you send for the levels of T3 and T4, the free ones are better because the bound one is bound to the protein serum. The rationale of sending. So like consider you have a case of diabetic foot, and if you think that you want to send CBC, then why would you send it? Then you can say that I would want to see for leukocytosis, I want to see for hemoglobin levels, so that if that requires optimization. That is the kind of answer that your examiner wants. Okay? Not just the label. And this is what is also expected in your theory. Clear? Okay. That's it. So USC, so any swelling, surgery subjecting is not, when you see a swelling, you should think of two things. USC, that is imaging, and second is tissue diagnosis, which is FNC or wherever applicable biopsy. So USC and FNC, the limitation of FNC is what? You do not see, you cannot differentiate between carcinoma in situ and invasive CA or follicular adenoma versus follicular carcinoma. Excess of tissue neck sometimes helps laterally, it is taken from hyperthyroid patient. If the management is hyperthyroidism, some Graves, which is the commonest condition for hyperthyroidism. the management is you would control, get the patient euthyroid with treatment. How long will you keep the treatment? Maybe a year and a half, maybe 2 years, or if there are any side effects, right? Then you would offer surgery. Which surgery will we offer? Total thyroidectomy. Clear? Total thyroidectomy. Now that keeping 8 grams of thyroid and implanting it, it is not common here. What we do is total thyroidectomy followed by lifelong supplementation of thyroxine. This is already explained to the patient, right? So this is one. Now if there is solitary thyroid nodule on one side, okay, the patient is resting on one side and the patient is euthyroid. In those cases we offer hemithyroid. Why hemi? Because in thyroid we do not do biopsies. And FNAC only can provide you with some value, not more than that. So what do? You remove one part, send it for biopsy. Okay, peripheral arterial diseases. This is your another long case. So, standard questions are intermittent claudication. How does it differ from routine pain? Right. So, intermittent claudication would happen in muscles. It is because of muscle ischemia, and IC would happen slightly distal to the block. So if the block is somewhere in profitability or femoral artery, then IC would happen in calf muscles. But if the block is in the popliteal artery, then IC would happen even below. Maybe calf and foot. Boyd's classification everybody knows. 4 grades. 4th grade is rest pain. Always remember how to differentiate. How do you say that it is rest pain? Rest pain is ischemic nerves. So it is no more inflammatory pain. It is ischemic pain. Right? It is ischemic because those nerves are no more getting any blood. So it is ischemic pain. And that is why it is relentless, and no matter what you give, it just does not help the patient. So the question you ask is, can you sleep at night? So if the patient says, no, I cannot sleep, you already know. Now if you have a case of PVD in your exam, so you already see the patient sitting by the side of the cot with his foot hanging. Most likely the patient would already have rest pain. Okay? So this is to give you an idea, and then you already know that this is an advanced disease. And then you can say this to your examiner, that the patient prefers to sit by keeping his feet hanging by the side of the cot. If there is any ulcer or gangrene, ulcer I have to describe the way you describe ulcer, and what to speak, I'll tell you. Gangrene, dry gangrene and wet gangrene. Dry gangrene happens in case of acute obstruction. Acute arterial obstruction has 5 P's. Everybody knows those 5 P's? Pallor, voiceless, thirstition, paralysis, loss of function. Pain, sorry, 5th P is pain. Boyd's classification I just told you. So in history, apart from pain and ulcer, now what negative history? I talked about negative history in other cases. How would you ask for which other questions should you ask for? So if there is ischemia in the lower limb, think about ischemia at other arterial places, or consider other arteries also involved. So if you would see cardiac arteries involved, coronary arteries, then you need to ask for chest pain or breathlessness. If there is cerebral artery, so carotid involvement, you can ask for history of TIAs, or if there are any visual blackouts, any history of stroke again. If there is GI arterial involvement, the signs of ischemia, these are common things. So overall the limbs would appear thinner, right? Now think that all the integuments of the skin have stopped receiving blood supply. Because skin is even minor ulcerations apart from the major one. If there is ulcer or gangrene, you have to describe that. These are standard theory questions, but I think lower limb, all 4 arteries, that is femoral, popliteal, dorsal pedis, and posterior DP and TPA. These 4 arteries you must know how to palpate. And if you cannot palpate popliteal, it is okay. So don't bluff. Okay, so if you think you have not palpated popliteal, then don't bluff, because it's somewhere difficult for us also to palpate popliteal. But for the rest of it, I think if you just even if you palpate each other's arteries, you will be able to know that this is DPA exactly as it can. I think it's very simple to do. But in case of PVD, you also need to palpate carotid. You also need to palpate upper limb arteries, and you also need to speak about it. Okay. Other tests are you need to auscultate or bruit, because at palpation there can be bruit. Berger's postural test. All these tests in PVD and in varicose vein, they are usually of historical importance only. Okay, we usually don't do these tests. So Berger's test where you elevate the leg and then see at what angle the little totally gets covered and gets pale. It's not routine data because in most complexions it would be very difficult to identify. Plus, it does not provide you with any meaningful interpretation to manage the patient. Capillary filling time and then nail bed blanching, etc. These are also to be done and you need to see. So now comes investigations. Again, I told you two prongs. One is for diagnosis and the second is for to identify the etiology. So blood work, CPC, you want to see if there is any leukocytosis, you want to see what the lipid profile is like, if the patient is diabetic, and if it is, then what's the status, if there is any patient has any comorbid conditions, right, protein C or S deficiencies. ABPA is part of investigation. Endovascular pressure index 0.9 to 1.3 is normal. Anything less than 0.9 is some amount of ischemia. Imaging is duplex ultrasound. So duplex ultrasound is different than routine ultrasound in terms of it has a keyboard ultrasound, and then there is another ultrasound. Two ultrasounds are used. So first one would image, and the second one would, so to speak, color it, so that the blood flow that is going towards it and going away from it, they would color it blue and red. So duplex ultrasound is your primary investigation. If there is any major block is expected, then what do we do? Then CT angiography is advised. CT angiography is also talk about crystallography is very good in imaging. Aortoileum and on thoracic cartilage. The thorax you cannot image with ultrasound. There is bone, so you cannot image thorax with ultrasound. General optimization, hemoglobin and protein comorbidity, whichever are there, real strict monitoring and control of them. Stop smoking should hit them. Like हमने जरूर पूछा PVD का patient का what is the management? The first thing you should say is stop smoking. So it's part of management. So do not just assume that my examiner already knows that of course smoking is not. No, you say. Drugs usually use that pentoxifene, cilostazol, rivaroxaban recently. If it is acute obstruction, then you would sterilize so as to normalize. And finally, procedures. So the same procedures that are done for heart. So if somebody has a angina or ischemic heart disease, we do PTCA and we do bypass. So those two things are also done, but they are done for major blocks because you need some diameter of the artery in order for you to perform surgery, right? Varicose vein, importance is that of profession, pain, which is usually in calf, usually in the evening. This is important. And some examiners may ask you that is it really pain? So then you can say it's not actually pain, but it can be called as heaviness, fullness, engorgement, etc. Right? Itching and ulcer. So in varicose vein there can be three symptoms. So one is visible veins, second is visible veins, then itching, which is eczema, and third is ulcer. Past history of DVT, drugs, or any prothrombotic state, which are physiological prothrombotic states in human body. Pregnancy is one, right? So after pregnancy, venous thrombosis is common. So that I should not say that all pregnant women develop this, but it is one of the causes. So examination again, as I told you, standing, and you have to say that I examined this patient in standing position. You don't assume it. Medially, you would of course know the root of great success when just behind the medial malleus, medial side of the leg and thigh, and enters 2.5 centimeter below and height into the tubercle, which is the opening of circumfemoral junction. Now, when you palpate that, vein, there are times when you'll be able to palpate the incompetent perforator in terms of dips. You will only be able to palpate it, I cannot describe it. But if there is a vein, and if you palpate along its course, you will be able to palpate as in gaps or dips. Other things that are done is now there are plenty of tests described in ESDAS and other clinical books. Almost none of them are done, including tourniquet test. But we will still talk about it. So percussion retrograde. What is retrograde in lower limb? Proximal to distal. Normal is distal to proximal. So retrograde in lower limb is proximal to distal. So the patient is lying, the vein is full. If you tap on one side, if it travels, if the wave travels, that is known as percussion wave. You want to see for skin around the ankle. Now, common questions are: what is Gator's area? Exactly, medial barriers, right? You also read about what is Gator. What actually is Gator? Read about it. Gator's area, why is it the commonest place for ulcer development? Because it is the point of maximum ambulatory venous hypertension. So when someone is walking or someone is standing, it is that place where the entire column of blood is resting. So you can imagine that it is like literally holding a lot of weight on it, right? So that is where those veins, they start giving up capillaries. And when they start giving up, they tear, the RBCs then go in subcutaneous tissue, they are destroyed, hemosiderin is released, that causes local inflammation, which then causes eczema, eventually ulcer. So body triangle test, when you will ask the patient to lie down or empty all the veins by palpating, and once you do that, you will one thigh and three in the leg, right above the ankle and do one in mid leg and the upper leg. How do you apply it if at all you are asked? So take a catheter, apply it, and then maybe you can occlude with an artery forceps. Fine. Again, duplex and other relevant investigation for thrombotic state. What is management? So management is manage the vein, manage the eczema or ulcer, whatever is their indication. So the management of varicose vein is the large trunk is involved, main trunk, sacrofemoral junction vein competence, so removal of the vein, which is septenectomy, also known as varicose vein stripping, that is done. Okay. If it is only perforators, so the main trunk is not gone, only perforators are gone, then you may try sclerotherapy, injection sclerotherapy, but that has to be done in the US guidance. What are the complications of sclerotherapy? Deep venous thrombosis, right? And secondly, any management of superficial varicose vein, which means affection of superficial system, requires that you have intact deep venous system, right? So the only contraindication to removing the superficial vein is that there is deep venous thrombosis, because that system is not working, this one is working partially, and if you remove this one also, the patient will develop venous gangrene. Typical question is, how would you manage the venous ulcer? Which kind of dressing is done on venous ulcer? Saline dressing. Okay, what you should say is saline dressing. Few short cases, then we'll call it a day. Sebaceous cyst, dermoid cyst, you all know standard thing. Sebaceous cyst, it would have a puncture. Management is removal. You can still get FNSC. It can happen in almost all cases wherever there are sebaceous glands. Dermoid cysts are where congenially two segments are joining. That is when they can be there. Common ones are post-auricular, near the eye, and under the eye, etc. Again, the management is removal under anesthesia. Lipomas are very common, can happen everywhere. Then they may ask you that do you need to remove all the lipomas? Then you can say that it's not urgency, but if it is at a place where it is hurting the patient, consider somebody has lipoma in the axilla or in the medial side of the thigh where it keeps on rubbing against then I would offer. What is multiple lipomatosis, numerous lipomas all over the body, do they all require removal? No, they don't. Ulcer. So you want to remember that common causes of ulcer, when you are asked, then it can be diabetic, it can be infective and traumatic. These three are very common causes of lower limb ulcer, foot ulcer, which you will have a case of. Whenever you have a case of ulcer, It's like what is granulation tissue you are expected to know, what is soft you are expected to know. Right? If you do not know them, then there is a problem. Right? So if your examiner is asking you these basic definitions, you get it? Because now we have to come to the most foundational things that chalo at least I do boli jato. Right? So okay, so let me get back. So ulcer, you must know how to describe it. Again, a single ulcer of 4 cross 4 centimeter size is present on the dorsum of right feet, which is approximately 2 centimeters from the root of the great toe and about 3 centimeters from the median malleus, something of that sort. So try to make a single sentence. And then once the examiner has an idea of where the ulcer is, then you start from laterally, what the margin is like, what the edge is like, and what the floor is like, what the ulcer is resting on. And then if at all, now see, if you think that there's a dressing lying right beside the patient, the dressing was done in the morning and it's lying right beside the patient, the dressing is drenched in pus, right? So you should have noticed it. You don't need to clean it. But then it should form that, then you cannot say that there is no discharge. It's already right there. And if you want to say that there is no discharge, then you get rid of that thing. Right? Clear? I mean, common sense, right? This is nothing with no rocket science here, right? So common definitions, enterostomy, ileostomy, and colostomy are also common cases. In standard textbook stuff, how we differentiate through the effluent. The first thing you say is through the site. How would you differentiate between ileostomy and colostomy? The first thing you say is site. Okay? The way you talk about site, the first thing in ulcer and insulin, the same way here also, that's what you do. Okay? The indications, etc. are theoretical question, but examination. When you examine it, what you have to say is the condition of the bowel. So what would you say? The bowel is clean. There is no edema. The bowel is clean. There is no edema. There is no prolapse also if there is no flow. And there is no retraction also. So the bowel is clean. There is no edema. There is no prolapse, no retraction. And then it is well functioning. So if you already are seeing some effluent in the bag, it's well functioning, right? So this examination part is important. Then you need to talk about the surrounding skin. If it has been kept totally open, you will be able to see. It has not been kept totally open. And if you ask them, somebody said, no, we didn't get the bag and yesterday we got the bag, we don't know to remove it. So they don't talk about the skin. Then if you have not seen, then don't say. Okay, usually when is ileostomy or colostomy is closed? 6 weeks, 1.5 months. Why that much time? So that the primary pathology is under control, the patient is doing well, and peritonitis has been taken care of. But can we go longer than that? Yes. Can we go shorter than that? Preferably no. Okay? And before that, what do we get done? Before you close, what investigation will be done? There is something known as loophole. So what you would do is you would inject some dye in the distal loop